Good evening, everyone present here. I am Faraz from IGCP Group. Welcome all the participants on today's webinar. Let's welcome our speaker with great honor, none other than Dr. Jaideep Malhotra, ma'am. And let me share some of the achievement of ma'am. Ma'am has done MBBS, MD in obstetric and gynecology, and she is managing director of Rainbow IVF Agra. And today she is going to discuss on a very important topic, that is premature ovarian insufficiency. And by taking not much time to know more about this topic, I would like to invite ma'am and hand over this session to ma'am. Ma'am, stage is yours. You can proceed from here.
Thank you so much, Faraz. Thank you. And a very good evening to all of you. Today, I'm going to discuss a very important aspect of premature ovarian insufficiency because this is something which has been much more prevalent in our country than in the Western world, and it definitely needs our attention. So, I'm just going to ask you a question because, as a doctor, it's not very uncommon that in my clinic, a young couple will walk in. They've been married only for 2 years. Their ages are also between 26 and 30, anxious to conceive, and on asking when that what is a menstrual history like, the wife complains that she had regular periods till about 8 months, but now her cycles are much shorter. They're coming a little, after 22 days. And in spite of trying for almost last 1 year, she has not been able to conceive. When I do an ultrasound scan, both the ovaries are very small. Her AMH report also is very disheartening because AMH is also very low, and FSH is also above like the menstrual the menopause stage, the 28 international units. Husband is normal. I'll take you to another scenario where a 30-year-old corporate manager inquires about egg freezing, as she has no intention of getting married right now, and everything otherwise seems very normal, and she says that since nothing is there in store for me, can I go ahead and freeze my eggs? I said, of course you can, but let's at least do the preliminary check. And when I do a scan, her ovaries, as you can see, hardly had any follicles, and also her hormone reports were quite low. Now, this is something which we have to understand, that there's a difference between men and women. Women are born with a finite stock of eggs, and they may be about a 1 million as after puberty, but out of that 1 million, only about 400 to 500 actually ovulate. Now, as we look at the decline in fertility, normally is much faster, if you can see here, after about 35 years. Now these figures are for the Western world. What happens in our country is again very important for us to understand, because in our country, if you see here, this fall is in a much larger number, because in the Western world we say about 1% of the women can have this issue where their egg reserve will be much lower than for their age. But in our country those figures are between 3.5 to 5.5 percent, and that's a lot. So if I now define premature ovarian insufficiency for you, it is the loss of that normal ovarian function before the age of 40 years. Now, this condition actually affects about 1% of the women under 40 globally. But in our country, the figures hover around 3% to 5.5%, which is a huge shift from the normal precedence. Now, what is more important here is that in our country, we no longer take the cutoff of 35 years where the decline is faster. Because we have to understand that in our country, the age of menopause is much lower. In the Western world, it's between 51 to 55. In our country, the average age of menopause is 46.5. So for us, that 35 cutoff is much earlier. So we cannot follow the West as we normally are used to following all the evidences from the West. Now, how do you really define premature ovarian insufficiency? As I said, that it is a clinical syndrome where there's a loss of ovarian activity much before 40 years. Now, how do you really understand that, and how is it really characterized by? Women can come with different kinds of history where they may have amenorrhea, no periods, or the periods are coming much earlier, or they have had amenorrhea for about 4 months. When you do the FSH reports, then FSH will be more than 25 international units on more than two occasions, which are like 4 weeks apart. And the estrogen levels are also low, like less than 50 picomoles. You could actually do many other tests, but they're really not really required. Now, why don't we call it failure? Now, there's a difference between premature ovarian failure and premature ovarian insufficiency, because failure means that they're not going to ovulate, and so there's no chance of a pregnancy. And premature ovarian failure before 40 is what we are looking at. But premature ovarian insufficiency is something where there's a lesser reserve, but they can ovulate. So that means that they can also get pregnant also, sometimes. Now, what is behind the etiology of premature ovarian insufficiency? Now, it could be totally spontaneous, idiopathic. There can be many genetic reasons for it. It could also be autoimmune ovarian damage because of infections and other things. And it could be also induced because of, the chemotherapy or the radiations, and sometimes surgical operations which may lead to premature ovarian insufficiency, and a lot of environmental toxins are also responsible for it. Now, why it is important for us to worry about it, especially about the genetic causes, because we have to understand that there are some genetic mutations which are very common amongst siblings. So boys and girls, or sisters who are having this fragile X can have premature ovarian insufficiency, and also sometimes their brothers and sisters can have other issues. Now, when one person in the family has this issue, it is very important for us to ask, how their siblings are, and then look at their reproductive functions also, because if we detect this early, we are able to sort of help them with cryopreservation, and that's something which is very, very important. And that fertility preservation awareness needs to be created. Now, another very important aspect which we normally ignore is that there are a lot of environmental endocrine disruptors which may be responsible for this fast decrease in the oocyte quantity in our ovaries. And this can happen at any stage. It could happen to a female baby in the mother's womb, the fetal ovary, or, otherwise to all of us when we are exposed to it. And these are very common everyday use things which have bisphenol A. And what we have seen is they're contained in all these plastic containers or sealants, or a lot of these things which we are exposed to, the cosmetics which we use, and the fast food which we eat. There's so many things which have bisphenol A. And this bisphenol A, whenever a fetus is exposed to it, female fetus, then it leads to oocyte loss. Chromosomally abnormal eggs are there, and even the embryos in the adult females are going to be abnormal. So if you understand this, that it has effect on the coming two generations, and that's very, very scary. Now, along with this, there are many of these endocrine disruptors which we are using every day, or we are exposed to environmentally, which actually have an effect on all the stages of egg formation or oogenesis, and also on all the stages of steroidogenesis. Now, and this can really have an effect on us overall in decreasing the oocyte number, the quality, and increasing the abnormality in the eggs, and ruining our hormones. They are obesogens, they are diabetogens, so they can harm us in many other ways. Now, how do you really investigate? Mostly, the diagnostic criterias I have already told you. But if required, we could probably look at the genetic analysis, a karyotype, a fragile X or fMRI permutation testing can be done, and the other baseline investigations also can be done. Now, why is it important for us to understand and look at this entity as a whole? Because when this problem happens, there are a lot of long term consequences. Fertility is not the only one. There are a lot of other long term consequences that can be there, and they actually, if we are aware, can be prevented. So, what are the long term risks of premature ovarian insufficiency? Let us understand that there could be these. Women are more likely to have a premature death because of early menopause, and most of the time the cardiovascular aspects of menopause. There's an impact on the bone health, so are more likely to have osteopenia, osteoporosis, and fractures much earlier in life. The cardiovascular risks and accidents are also very much predominant in them. There could be thyroid impairment, cognitive impairment, and also autoimmune diseases like vitiligo, hyperpigmentation can be very, very common in these women. And these women can also have a lot of psychological effects with, like poor self esteem, less satisfaction in life, quality of life is not there. There could be depression, anxiety, mood swings, and so on. Now, since premature ovarian insufficiency can happen at any age, even young adolescent girls can have reproductive age group. Fertility is something which comes at a much later age. So the management goals are also according to at what stage this has been really discovered, or we've been able to diagnose, and then the goals of management also are accordingly. I don't have much time to go into the depth, but I can tell you that yes, if we find ovarian insufficiency in a young girl, and if we are able to diagnose it much earlier, then their hormone therapy has to start basically much early to initiate puberty, because otherwise their bone health, their epiphyseal closing, and many other issues as far as their growth is concerned and their whole body profile is concerned is going to be really at a much lower end. Now, another important thing is that in case if they have genetic problems, like quite a few of them can have Turner syndrome. Now, again, Turner syndrome can be diagnosed because the profile is, the phenotype is very much, you can diagnose it by having a look at these girls and their growth. Then we need to also initiate the hormone therapy much earlier. Now, what hormone therapy? I think it's going to be a lecture on its own, but it is really required. And we normally, before the epiphysis closes in these girls, we initiate the hormone therapy with estrogen. Once they have a low dose of estrogen, once they have a breakthrough bleeding with that estrogen, then progesterone is the one which is added, and this can be continued for the time till they reach a age of normal natural menopause. Now, a lot of juggling, especially if fertility is intended, then what combination of estrogen and progesterone is something which can be discussed and then decided on those circumstances. But yes, today we have a lot of these formulations which are available and which can actually be used. Now, a little later in the reproductive age group, it's not only the fertility which is a problem, but sexual function is also, which can really have a difficulty in the quality of life these women may have, and also have an effect on them psychologically. So, a decreased sexual well being, they may have problems with arousal frequency, and have pain during sexual intercourse, which is can be really taken care of by good counseling, and then addition of hormone therapy, which could be estrogens, and in some cases we might also need a little androgen supplementation, and that should be done wherever required. Let's come to fertility now, because In this particular entity, the difference between failure and insufficiency is that about 2 to about 10 or 14% of these women can actually have spontaneous pregnancy, and which may not happen in a premature ovarian failure. Now, what is important here is now how to decide. We can't jump to conclusions when we look at an FSH of more than 25 and say, oh, you can't have a baby, because she may just come next month with a pregnancy test, and that's something which we have to keep in mind and have to be mindful of how we counsel them. So, when we look at an established premature ovarian insufficiency, first thing we have to tell them is that they can conceive naturally, but who has to be left for natural conception, why they have to be left, and what needs to be done, what investigations have to be done, all those things should be in place. Sometimes they may come at a stage where they don't want a pregnancy, but they can get pregnant. Those people can be put on contraceptives. Now, whenever they are intending fertility, now what is important for us to understand is that uh, mostly ovulation induction and all cannot, we don't have much results with these. And mostly these women do well with oocyte donation. But today we have a lot of these newer treatment modalities or management things which are coming up, like we have ovarian PRP, and we have stem cells which are coming up, and then fertility preservation is another very big aspect which should definitely be offered to them. Now, the most important aspect is to look at women who are at risk of POI. Now, those are the ones, if they are identified much earlier, will do very well with oocyte or embryo cryopreservation, or even ovarian tissue cryopreservation, which are very, very important. So, looking at the treatment of fertility issues, yes, though ovarian stimulation does not help much, but can be tried. We can do egg or embryo accumulation, which can also be, a very, very important, especially for young girls who are not really looking into fertility at this particular time. And then there is a lot of these cutting edge technology which is coming up. Now we have, injections of platelet rich plasma into the ovaries, which is very new. We haven't much evidence for it, but also we have transplantation of the mesenchymal stem cells, which are there. And there are a few things in the lab which we can do, is like in vitro activation of the dormant primordial follicles. All those can be done. Here is a small video which I'm showing about ovarian PRP. That's platelet-rich plasma, which is prepared, activated, and then injected into the ovary. Normally, because these ovaries are very small, we do it laparoscopically. And this about 1 or 2 ml of platelet-rich plasma is injected. And then we wait for about 6 weeks to 2 months to then stimulate these ovaries. Otherwise, similarly, this also can be done now ultrasonographically guided, and that again is something which uh, is then becomes very, very non-invasive. And if you can see here, if you stimulate the ovary, then it becomes a little more easier, because these ovaries are very small, and sometimes it is, and they're also hard to inject. So sometimes those can pose issues as far as the injection is concerned. Now, how does PRP actually help? Now, if you understand, PRP is being used uh, all over the world for many things. Like, the dentists are using, the cosmetologists are using, and we are using in our fraternity in gynecology for endometrial, thin endometrium. And now, very recently, we started using for ovarian rejuvenation. Now, the platelet-rich plasma has a very high concentration of platelets, and there are a lot of these bioactive proteins which promote, cell proliferation and differentiation. And these may also improve the concentration of the hormones and the growth factors, which may help. Now, whether this helps or not, Uh, Time is going to tell, because you really need large numbers and a lot of more evidence. Like, the primary evidence does not really suggest, but I normally do not really go by the evidence, because there will be a few cases and which will definitely be benefited, and there will be a few cases which may not. So when we are looking at evidence, it keeps on changing with the practices, and the numbers change. So I think we still need to wait for it. But these are a few of our preliminary results. And if you see here, this one particular case who was 36 years old and had very low AMH, had an IVF cycle somewhere else. She never got any eggs, and she had done embryo donation with no pregnancy. And then she comes to us, we do a PRP, and in the next cycle itself, we get about six M2s, and we got two blastocysts in that IVF cycle, which were transferred, and she is pregnant. And here's a list of many other cases, out of which about 30% have had a pregnancy, and about 30% have not had a transfer. So we I feel that it is something which can really be tried. Now, apart from PRP, stem cells are also coming up in a big way. Now, these stem cells can be extracted from the bone marrow, or the amniotic fluid or the menstrual fluid, from anywhere. But the basic reason and the way of functioning of these stem cells is that they can really help in homing, differentiation, and the paracrine and the other functions of the body. Now, the mesenchymal stem cells, again, because it's a very new entity, when they're transplanted into any body, I mean, they can, basically lose their characteristic and have end up into a high proliferation and tumor formation. That is one thing which we are really scared of. But the applications of stem cells have been there, for a long time now, and I feel that in future much is going to come out of it. Now, in vitro activation again can be done, but what is very important for these patients is that fertility preservation is something which should be offered to them. If they're not married, or if they're married and they're not wanting to get um, pregnant, then oocyte accumulation or embryo accumulation for the married ones is the one which we can offer. But supposing if you're doing a surgical procedure for an endometrioma, and you are going to remove the endometrioma cyst, but if we take a few cortical strips and freeze the ovarian tissue, then later on these women, whenever they want fertility, or if they don't want fertility, even their hormone therapy will not be required if this auto transplantation of the ovarian tissue can be done. So we must offer the fertility preservation to all these women, whether it's in the form of embryo, oocyte, or ovarian tissue. Now, different ways of fertility preservation have been tested, but what is important today, that and is functioning very well, is the embryo preservation, which is really time tested. But oocyte also is giving equally good results. And there aren't much number of cases as far as ovarian tissue transplantation is concerned, but I think it also needs a lot of awareness, which is very, very important. Now, there are many other things which we can do in our labs, especially, injection of mitochondria, which can be injected along with the sperm into the oocytes. And this can actually be energy providers for these oocytes which are there. Now, what is coming up are also exosomes. Now, what is an exosome? These are very small nano-sized particles which are, actually secreted by the the cells. Now, these exosomes are not really cells, these are secretions, and they act as a mediator for the intercellular communication or and the material exchange. Now, these exosomes have very high percentage of growth factors, cytokines and chemokines. So they probably tomorrow can maybe a replacement for the stem cells and also for the PRP. Now, what works well with these women if their own eggs are not there? So, oocyte donation is the standard treatment for these premature ovarian insufficiency women if they are looking at fertility. Now, the most important aspect is that yes, it is. It can give you very high live birth rates, and there are not many complications. Just a few complications are maybe there where the obstetric complications are increased with donated oocytes, and those actually can be really taken care of. I'd like to give a word of caution here, especially when women come with premature ovarian insufficiency, and when we offer them oocyte donation, we must always do a proper cardiac check, because quite a few of them can have Turner's syndrome. And whenever Turner syndrome is there, these women have more chances of having aortic arch and aortic valve abnormalities. And during pregnancy, aortic dissection is something which can happen. So a proper cardiac check is very, very important, because you may give her a pregnancy, but we may lose her and the baby during labor and delivery, and that is something which is not really asked for. So, lastly, there are a lot of these emerging technologies also which are coming up, which may help us in prevention of ovarian fibrosis, which can happen, with age. Metformin is one of them, which is under testing these days, and there are quite a few drugs which actually block the DNA damage and may help prevention of the cell death which happens in these ovaries. But only time will tell us what the which of these technologies is actually really going to help us. So I'd really like to conclude here and say that premature ovarian insufficiency is actually a public health priority, because in India the prevalence rate is much, much higher. Now, what is important is that we can't write off these women and say that, oh, you can't get pregnant. Firstly, second important thing is that when we detect this earlier, we must offer hormone therapy to these women to prevent them from the long term consequences of this estrogen insufficiency, which actually will bring all the problems of menopause much, much earlier in them. And whenever we start hormone therapy, we must also continue it till the natural age of menopause, or maybe even later, because it does definitely prevent a lot of long term consequences which are there. And second important thing, that the sexual dysfunction also can be very common in these women, and a timely detection and a lot of professional physical and psychological help in these, along with androgen replacement, can help them overcome all these problems which can affect their quality of life. Tomorrow, a lot of innovative treatments may be available. Let us hope that we are able to help our women in the best possible way. But what can we do right now? Right now, what is important for us is to create awareness regarding this. A lot of these social media and digital and other platforms definitely should educate women, because today girls are getting educated. They are much more career oriented, and once they are marrying late, once they marry, they are not wanting to have children earlier, and by the time they are ready for children, about 5% of these women can have premature ovarian insufficiency, which had they known earlier, they could have opted for fertility preservation. And that is something I feel all of us should be engaging in. So I'd really like to thank each and every one of you for your patient hearing, and let's hope that we are able to have much better solutions for this entity. Thank you so much.
Thank you so much, ma'am, for taking out your valuable time and sharing your knowledge on this topic. I definitely think this session knowledge is going to help all the participants who have joined this session. I can see, ma'am, we have received some question. With all your permission, shall we take the
Sure.
questions?
Sure.
The first question is from Dr. Subramaniam. He's asking, are there any specific contraindications for HRT in women with POI, and what alternative treatments are recommended in such cases?
See, most of the times they're not, because these women are really young, and hormone therapy per se, there has been a lot of, I would say, hullabaloo about hormone therapy. Hormone therapy is not as bad. It can very easily be given to most of them, and especially these are very young women. And as I said, sometimes we might have to also initiate it much earlier in life, because we, like young girls who haven't really had puberty, to initiate puberty also may be required. But we do definitely do the basic investigations as far as their cardiac checks, their lipid profiles, and other things are concerned, the X-rays, which need to be done before initiating, and a family history of thromboembolic phenomena and the certain kinds of malignancies which need to be taken. And once you put them on hormone therapy, yes, close monitoring is also important.
Thank you so much, ma'am, for sharing your point. I hope that Dr. Subramaniam has received his answer. Another question is from Dr. Agnihotre, and he is asking, what are the most effective ways to console patient and their families about the implications of POI diagnosis?
See, again, it can be very challenging, especially if they have some genetic problems, as we if somebody is Turner syndrome, if they have some gonadal dysgenesis or some. So it has to be tackled very with a lot of caution. I can tell you one story, I mean, which is a real time experience for me, which happened. Um, the couple comes, and they already had done all the preliminary tests and everything there. Even a karyotype was done, and once the karyotype was done, the doctor gave the report, but the doctor did not tell them anything. Now, I was also very new to this entity. This happened about 25, 30 years back. And and I had to counsel them for egg donation. Now the husband is asking, why egg donation? Why is my wife not really able to produce, eggs and all those? I had to tell him that, she has some genetic problems, and with because of this genetic problem, she is unable to produce eggs, and we have to do egg donation for her. And he goes back, and he gets goes to a genetic counselor, and the genetic counselor tells that your wife has XY instead of XX. So now he comes back and he says, oh, I have married a man, I don't. And the whole marriage went for a toss. Now it can happen, and that's where it's a very, very sensitive issue. It needs to be counseled well. But when we are looking at fragile X, it is easier to counsel. We can tell them, because of these genetic mutations, the egg number is less, your siblings can have these problems, so please go for fertility preservation. But there could be certain other issues which can have a lot of issues. But other times when radiation or chemotherapy is being given, it's again easier to counsel, because we know the effects of radiotherapy and chemotherapy will have on the ovaries. And even when I'm thinking about the other causes, like somebody has to go through a surgery, and I have to counsel them, okay, if I can take a cortical strip and freeze it, all those counselings are much, much easier. But sometimes the genetic counseling can be very difficult, and we should leave them for the genetic counselors who are more adept in counseling these patients, take their help. I can't hear you. I can't hear you. You're muted for
Discussing on
us.
this. Can you hear me, ma'am? Hello.
Yeah, yeah.
Ma'am, thank you so much, ma'am, for sharing your insight on this question. I hope that it will be very much impactful to all the viewers who are watching this session, ma'am. As I can see, there is no more question, ma'am. With all your permission, shall we
Can
conclude
I
this
tell you
session
one
for today?
story? If we have time, I want to tell you one very
Yeah,
real
ma'am,
time
sure.
experience, if you have. Um,
Yes, ma'am, sure. You can share it.
my one of my daughter's friends, she was in her early 30s, and she came to me with that, auntie, I don't want to get married. and can you please, freeze my eggs? Now, when I went through her scan and her reports, her AMH was very, very low. We did about 4 cycles of oocyte cryopreservation for her. We got in 4 cycles, we got only 8 eggs. We froze all those, and in the meantime, only she got married in the span of 6 months of time when we were doing this. Now, after her marriage, she comes back again after 2, 3 months that now I want to utilize those eggs. Let me have a baby, because by the time she was quite scared that she will not be able to have a pregnancy. So I said, no, no, you go back and try, because we have backup. We'll use it whenever required. And can you believe it? Within 6 months of her marriage, she was pregnant and she's about to now deliver. So the moral of the story is that, do the right preservation whenever it is required, but don't use it unless and until we have given them, enough time till they're ovulating. Because if they're young girls, give them time, and the preserved material can actually be used if they don't conceive, or for their second child also. So a lot of thought, and positive, I would say, insightful thinking and mindful management is required in these patients.
Thank you, ma'am, for sharing this story too. I hope it will be help all the audience for the awareness also. Like people
Yes.
are scared for the new, like egg freezing is a new thing in Indian scenario. I hope, ma'am, this will be create awareness too among the like among the audience for sharing this real time story, ma'am. And ma'am, it
Thank
was
you.
really nice to have you, and we would like to see you in future also with different topic. Till then, take care of yourself, ma'am. It was really great
Thank
to
you.
have you. And Happy New Year
Thank
in
you so
advance,
much.
ma'am.
Thank
Thank
you.
you.
Well, Happy New Year.